The distal esophagus is naturally lined with a smooth, stratified squamous epithelium. While resilient against food friction, it cannot handle corrosive gastric acid. Chronic gastroesophageal reflux disease, or GERD, forces stomach acid and bile upward into this channel. This persistent exposure results in a cycle of chemical injury and inflammation. As an adaptive response to this sustained damage, the body replaces the native squamous cells with acid-resistant columnar cells, a biological process known as metaplasia. These new cells include mucin-producing goblet cells. Their presence under histological examination is the specific requirement for a diagnosis of Barrett's esophagus. This specialized intestinal-type epithelium functions differently than the original lining. It produces a protective mucin layer, successfully shielding the underlying tissue from the acid environment. While this cellular change provides short-term protection, the shift in cell type introduces genetic instability. This new epithelium is more prone to the mutations that lead to cellular disorganization. By adapting to survive chemical injury, the esophagus has exchanged mucosal health for a direct physiological path toward malignancy. This progression follows a documented chronological sequence, beginning with intestinal metaplasia, followed by low-grade and high-grade dysplasia, and ultimately resulting in esophageal adenocarcinoma. Dysplasia represents the critical precancerous stage, where cells begin to exhibit abnormal growth patterns and architectural distortion within the mucosa. Under a microscope, dysplastic tissue shows severe cellular overcrowding and nuclear enlargement. However, these changes occur at the microscopic level, often leaving the surface intact. A physician may inspect a segment of Barrett's mucosa harboring advanced, high-grade dysplasia, yet find the tissue appears entirely uniform, pink, and healthy through the endoscope. Because high-definition cameras capture surface topology rather than cellular structure, the endoscope cannot reliably distinguish between stable metaplasia and high-grade precancerous changes. Visual inspection alone cannot identify these microscopic threats. Without a structured biopsy protocol, the most dangerous cellular changes remain hidden during routine examinations. As the endoscope descends, the pale squamous lining of the upper esophagus gives way to the distinct salmon-colored mucosa characteristic of Barrett's. This boundary, the squamo-columnar junction, marks the starting point from which Barrett's tissue extends proximally towards the esophagus. Clinicians use the Prague classification to document this. The C value records the circumferential extent, the height of the unbroken ring of metaplasia wrapping the esophageal wall. The M value measures the maximal extent, the longest individual tongue of Barrett's tissue projecting further up. Standardizing these measurements ensures that the exact dimensions of the affected area are communicated clearly between different physicians during subsequent surveillance endoscopies. By converting an irregular biological shape into a coordinate system, the Prague classification provides the baseline needed for systematic sampling. To find dysplasia that the camera cannot see, gastroenterologists employ the Seattle protocol, a strict spatial sampling algorithm. The process begins with a meticulous search for any macroscopic irregularities. The physician looks for nodules, plaques, or ulcers that break the uniform appearance of the mucosa. These visible lesions are the most likely to harbor advanced dysplasia, so they are biopsied or removed first, before systematic mapping begins. The remaining mucosa is mapped with a 4-quadrant approach, taking biopsies at the 12, 3, 6, and 9 o'clock positions. The physician then moves 2 centimeters up to repeat the capture. If dysplasia is suspected, the protocol tightens, taking biopsies every 1 centimeter. This increased sampling density provides a much higher resolution map of the tissue, though it significantly increases the complexity of the procedure. Increasing the number of samples to the 1 centimeter interval ensures that focal areas of high-grade dysplasia are not missed between biopsy sites. In a long segment of Barrett's tissue, this process can require dozens of separate biopsy specimens to ensure complete coverage. This labor-intensive mapping mathematically reduces the chance that microscopic precancerous cells evade detection, providing a rigorous check against the limitations of visual endoscopy. Once the pathology results are available, the highest grade of dysplasia identified determines the patient's clinical management. If no dysplasia is found, the patient remains in routine surveillance, returning for repeat endoscopy every 3 to 5 years. If the results are indeterminate, it usually means active inflammation from reflux is obscuring the cellular structure, making a definitive diagnosis impossible. The standard response is to intensify anti-reflux medication and repeat the endoscopy within 3 to 6 months once the inflammation has subsided. When low-grade or high-grade dysplasia is identified, the protocol requires confirmation by a second, independent expert gastrointestinal pathologist. This verification is mandatory because benign cellular changes caused by inflammation can mimic the appearance of true dysplasia, potentially leading to unnecessary intervention. Confirmed high-grade dysplasia is a critical clinical finding. Without intervention, it carries a significant risk of progressing to invasive adenocarcinoma. Dual expert confirmation ensures that the decision to proceed with physical eradication is based on the highest diagnostic certainty. For confirmed dysplasia, the clinical goal shifts from monitoring the tissue to actively eradicating it. Visible nodules are treated with endoscopic mucosal resection, or EMR. The physician uses a mechanical snare to excise the entire nodule from the esophageal wall. Unlike a standard biopsy that only takes a surface sample, EMR removes an intact block of tissue. These intact specimens allow the pathologist to evaluate the tissue architecture in 3 dimensions and determine the exact depth of cellular invasion. Knowing whether the abnormality is limited to the mucosal layer or has reached the submucosa is the primary factor in determining the risk of metastasis and the need for further treatment. After any visible lesions are resected, the remaining flat Barrett's tissue must also be addressed to prevent the development of new dysplastic areas. This is achieved through radiofrequency ablation. A specialized balloon catheter delivers thermal energy to the esophageal wall, vaporizing the superficial layer of the abnormal epithelium. The ablation is precisely calibrated to destroy only the superficial metaplastic cells. This allows the esophagus to heal by regenerating a healthy lining of native squamous cells. Integrating the PROG classification, the Seattle protocol, and these eradication techniques allows clinicians to identify and eliminate precancerous tissue before adenocarcinoma develops.